Acromegaly, etiology of acromegaly, growth growth hormone hypersecretion. So, acromegaly occurs due to growth hormone hypersecretion. So, this is usually the result of a somatotrope adenoma, but it may rarely be caused by extrapituitary lesions. So, why is this excessive growth hormone secretion? Because of a somatotrope adenoma, but this can also be caused by extrapituitary lesions. Extrapituitary lesions can also cause growth hormone hypersecretion. In addition to the more common growth hormone secreting somatotrope adenomas, we also have this mixed mammosomatotrope tumors and acidophilic stem cell adenomas. They secrete both growth hormone and prolactin. In addition to the growth hormone secreting somatotrope adenoma. So, growth hormone secretion is mostly done by a somatotrope adenoma. In addition to this, we also have a mixed mammosomatotrope tumors and acidophilic stem cell adenomas. They secrete both growth hormone and prolactin. In patients with acidophilic stem cell adenoma, features of hyperprolactinemia predominate over the less clinically evident signs of acromegaly. In acidophilic stem cell adenoma, so what features are more predominant? Features of hyperprolactinemia, that is hypogonadism and galactorrhea. So these features are predominant over the signs of acromegaly. Though growth hormone and prolactin both are secreted, in acidophilic stem cell adenoma, features of hyperprolactinemia are predominating. Occasionally, mixed plurihormonal tumors are encountered. They also secrete ACTH, the glycoprotein hormone alpha subunit, or TSH, in addition to growth hormone. Supposing if there are plurihormonal tumors, that is many hormones will be produced. So they also secrete ACTH, the glycoprotein hormone alpha subunit, or TSH, in addition to growth hormone. And patients with partial empty cella may present with growth hormone hypersecretion due to a small growth hormone secreting adenoma within the compressed rim of pituitary tissue. Patients who are having this partially empty cella, they also present with growth hormone hypersecretion because of a small growth hormone secreting adenoma. So this small growth hormone secreting adenoma, it is in the compressed rim of the pituitary tissue. So this reflects, that is the small tumor in the compressed rim of pituitary tissue. So this reflects the spontaneous necrosis of tumors that were previously larger. Previously tumor would have been big, it would have undergone a spontaneous necrosis. So because of this, there is in the compressed rim of pituitary tissue, this growth hormone secreting adenoma arises. Growth hormone secreting tumors, they rarely arise from ectopic pituitary tissue remnants in the nasopharynx or midline sinuses. So these tumors, they can rarely arise from the ectopic pituitary tissue. So this remnants are in the nasopharynx or the midline sinuses. And there are case reports of ectopic growth hormone secretion by tumors of pancreatic, ovarian, lung, or hematopoietic origin. So these tumors can rarely arise from ectopic pituitary tissue remnants in the nasopharynx or the midline sinuses. And there are also case reports wherein ectopic growth hormone secretion is from the tumors of, even in if tumors in the pancreas, ovary, lung, or from the hematopoietic origin. And rarely this excess growth hormone releasing hormone production may cause acromegaly because of chronic stimulation of somatotropes. So GHRH production So this will cause acromegaly because of the chronic stimulation of somatotropes. So these patients, they present with classic features of acromegaly. They will have elevated growth hormone levels, pituitary enlargement on MRI, and they will have pathological characteristics of pituitary hyperplasia. So if whenever there is a excess growth hormone releasing hormone production, so this will cause acromegaly. So this is because of the chronic stimulation of the somatotropes. So in these patients, what will happen? There will be features of acromegaly, and because of this growth hormone levels are elevated, there will be enlargement of the pituitary on MRI, and pathology will be that of a pituitary hyperplasia. The most common cause of GHRH mediated acromegaly is a chest or abdominal carcinoid tumor. What is the most common cause of GHRH mediated acromegaly? The most common cause is a chest or abdominal carcinoid tumor. So, although these tumors usually express positive GHRH immunoreactivity, clinical features of acromegaly are evident in only a minority of patients with carcinoid disease. These tumors, they usually express this abdominal carcinoid tumor or chest carcinoid tumor. They express this positive GHRH immunoreactivity. The clinical features of acromegaly are only in a minority of patients with carcinoid disease, and excessive GHRH also may be elaborated by hypothalamic tumors, usually choristomas or neuromas. If there are any tumors in the hypothalamus, usually choristomas or neuromas, so they also cause excessive secretion of GHRH from this choristoma or neuroma. So these are the causes of acromegaly. So pituitary, so this is the 98% prevalence, pituitary secretion of excess growth hormone. So in this we have this densely or sparsely granulated growth hormone cell adenoma. Then we have mixed growth hormone and prolactin cell adenoma. Then we have mammosomatotrope cell adenoma, plurihormonal adenoma, and then we have this multiple endocrine neoplasia 1, McCune-Albright syndrome, and it could also arise from ectopic sphenoid or parapharyngeal sinus, extrapituitary tumor in the form of, not from the pituitary, pancreatic islet cell tumor and lymphoma, and from central causes like hypothalamic hamartoma, choristoma, and ganglioneuroma. So this is all less than 1%, and peripheral causes include bronchial carcinoid, pancreatic islet cell tumor, small cell lung cancer, adrenal adenoma, medullary thyroid carcinoma, and pheochromocytoma. So these are the causes of acromegaly: excess growth hormone secretion, excess growth hormone releasing hormone secretion. That is the central cause, and peripheral causes. So these are less than 1%. Mostly it is by the excess growth hormone secretion from pituitary, 98%. The protein manifestations of growth hormone and IGF-1 hypersecretion are indolent and often are not clinically diagnosed for 10 years or more. That is, the clinical manifestations are indolent. To manifest, it will take 10 years or more. So this acral bony overgrowth, so this will result in frontal bossing, increased hand and foot size, mandibular enlargement with prognathism, and widened space between the lower incisor teeth. So because of this, what is happening? There will be a acral bony overgrowth. So because of this, what is happening? There will be frontal bossing, increased hand and foot size, mandibular enlargement with prognathism, and widened space between the lower incisor teeth. In children and adolescents, initiation of growth hormone hypersecretion before epiphyseal long bone closure. So this results in pituitary gigantism. That is, in children, if there is a growth hormone hypersecretion, so this is occurring before the epiphyseal long bone closure. So this will lead to pituitary gigantism. And soft tissue swelling, it will result in increased heel pad thickness, increased shoe or glove size, ring tightening, characteristic coarse facial features, and a large fleshy nose. Soft tissue swelling, because of soft tissue swelling, it will result in increased heel pad thickness, increased shoe or glove size, ring tightening will be there, coarse facial features, and a large fleshy nose. What are the other commonly encountered clinical features? Hyperhidrosis, a deep and hollow sounding voice, oily skin, arthropathy, kyphosis, carpal tunnel syndrome, proximal muscle weakness, acanthosis nigricans, and skin tags. What are the other encountered features? Hyperhidrosis, increased sweating, the voice will be a deep and hollow sounding voice, skin will be oily, arthropathy will be there, kyphosis will be there, carpal tunnel syndrome, proximal muscle weakness and fatigue, acanthosis nigricans, and skin tags. Hyperhidrosis, carpal tunnel syndrome, proximal muscle weakness, and generalized visceromegaly occurs. Generalized visceromegaly includes cardiomegaly will be there, macroglossia tongue enlargement, and thyroid gland enlargement. Even generalized visceromegaly also can be seen. So this includes cardiomegaly, macroglossia, and thyroid gland enlargement. So these are the features of acromegaly or gigantism. A 22-year-old man, due to excess growth hormone secretion, so this man, okay, and you can see the height and you can also see the prognathism in this man, and here the enlarged hand and foot of that man is seen. So what are the important things that has to be remembered? It arises from somatotrope adenomas, also from extrapituitary lesions. In acidophilic stem cell adenoma, features of hyperprolactinemia are predominant. So, pituitary growth hormones, densely or sparsely granulated growth hormone cell adenoma. Tumor would have undergone spontaneous necrosis. And protein manifestations or indolent. So, how many years it is taking? Not clinically diagnosed for 10 years or more. And if this hypersecretion before epiphyseal long bone closure, this results in pituitary gigantism. And GHRH excessive, it is from hypothalamic tumors, usually choristomas or neuromas. The most common cause of GHRH mediated acromegaly is a chest or abdominal carcinoid tumor. So this is about the etiology and the protein manifestations of growth hormone hypersecretion.